Welcome once again to our trauma and resuscitation course under Kampala Advanced Trauma Care course. I'm Dr. Gideon Kurigamba, and I'm going to be taking you through chest. In our outline, we are going to look at the global context, the epidemiology, pathophysiology, management strategies, stroke ideal treatment, especially in our low resource settings. Then we look at adaptations for low resource settings. And then finally, we shall have a case for discussion. And by the end of the teaching, our goals will be to identify and initiate treatment for common chest trauma injuries, including pneumothorax, which can be simple, tension, or open, hemothorax, frail chest and pulmonary contusion, cardiac tamponade, tracheobronchial tree injuries, aortic disruption, diaphragmatic injuries, and esophageal injury. In the global context and epidemiology, chest trauma accounts for 25% of deaths due to trauma, and for blunt chest trauma, about less than 10% will require operative intervention. Remember, our chest trauma we usually divide it into blunt chest trauma and penetrating chest trauma. And for the penetrating chest trauma, about 15 to 30% will require operative intervention. However, majority of the chest injuries require simple procedures. 90% of patients who sustain thoracic trauma can be managed conservatively with a chest tube, proper analgesia, because this is very key to improve the work of breathing, and good patient monitoring. In the pathophysiology, chest injuries often result in hypoxia, hypercarbia, and acidosis. Now, how do this come about? Usually, when you have chest trauma, for example, you have a hemothorax, you go into a state of hypovolemia because of blood loss. And also, the other thing is because of the injuries to the chest. For example, having contusions and hematomas within the intrathoracic cavity, there are issues with pulmonary ventilation, stroke perfusion, which gives us a pulmonary ventilation perfusion mismatch. And also changes in the intrathoracic pressure, for example, tension pneumothorax can give tissue hypoxia, which eventually leads to metabolic acidosis. And also we can have hypercarbia leading to respiratory acidosis, especially following inadequate ventilation due to changes in intrathoracic pressure relations. When a patient has poor ventilation, they are not able to blow off all the carbon dioxide, like patients who have pain due to rib fractures, and also patients who have a decreased or depressed level of consciousness. They have issues with breathing and blowing out carbon dioxide, and thus they end up with hypercarbia. Management strategies for traumatic chest injuries. One is that we always must remember our primary survey. This is a gold standard for all trauma patients. Our primary survey, our ABCs. A for airway, where we look at the patency and air exchange. Make sure that there is air exchange, where you can check with a piece of cotton on the patient's nose. B for breathing, to make sure that air goes into the chest and comes out. So under B, we want to expose the chest and the neck and observe for any signs of hypoxia or chest injury. And at this point, identify life-threatening injuries. And when we are looking at chest trauma, life-threatening injuries include tension pneumothorax, open pneumothorax, which is also can be a sucking chest wound, a frail chest, where we have fractures of ribs at least two ribs fracturing in two parallel planes, a massive hemothorax, and pulmonary contusion. And then under C, assess for pulses, assess for blood pressure, assess for neck veins. And under these also, remember to identify life-threatening injuries, which also include the tension pneumothorax, where you'll have a decreased blood pressure, distended neck veins, massive hemothorax, which will also give you a low BP, cardiac tamponade that also give you a low BP that gives you distended neck veins, and high pulse that is trying to compensate for the low blood pressure. And then always assess and reassess. And if there is any change in the patient's condition along the way, always go back to airway and reassess. And major problems, if a patient has any problem, these should be corrected as they are identified. If you identify a tension pneumothorax, correct it. If you identify an open pneumothorax, correct it. If you identify cardiac tamponade, correct it at this stage in the primary and secondary. So, do we start off with our tension pneumothorax? How do we initiate the clinical diagnosis for tension pneumothorax? Here, it's clinically, it reflects air under pressure in an affected pleural space, and treatment should not be delayed to wait for radiological confirmation. And how does a patient get a tension pneumothorax? So we have a one-way valve where air leaks occurs from the lung or through the chest wall, so it is a one-way, and then air is forced into this pleural space with no means of escaping. And so once there is no escape, it means now the lung on the affected side will be compressed and collapses. When this is not corrected, then progressively you have the mediastinum being displaced to the opposite side. For example, if you have the left side of the chest, the left hemithorax, having the tension pneumothorax, you have collapse of the left lung, and once the left lung collapses, then the mediastinum is shifted to the right, and so you have decreased venous return and compression also of the opposite lung, with eventually decreased cardiac output, since cardiac output depends on venous return, and thus the patient goes into obstructive shock. So clinical features of tension pneumothorax: 1, the patient will have chest pain. They come in with severe respiratory distress and with air hunger. Then tracheal deviation away from the side of injury, what we've already talked about, because of the shift in the mediastinum. Distended neck veins, because you have reduction in venous drainage because of the increased intrathoracic pressure. Hyperresonance on percussion on the affected side. And then you have the unilateral breath sound. So the side that has the tension pneumothorax, you will not hear anything, but you only have breath sounds on the contralateral side that is not affected. And then eventually these patients will get tachycardia as a compensatory mechanism, and then they go into hypotension and eventually obstructive shock, as we have already talked about before, and cyanosis, which is usually central cyanosis, but this is a very late feature. If you find this, then unlike the tension pneumothorax, how do we treat it? One is that it requires immediate decompression, and the immediate decompression, we want to use a large bore needle, and we go through our second intercostal space that is marked by that blue star on the right, mid-clavicular line. So draw a line through the clavicle, so second intercostal space, mid-clavicular line, and introduce a large bore needle, which we call needle thoracotomy, and that is the immediate needle decompression. but this does not relieve all the air. However, it releases majority of the air that is causing the emergency or the compression. But then definitively, we need to do chest tube insertion. And remember the point of our chest tube insertion, our triangle of safety, which is usually the sixth so between the fifth, from the fifth intercostal space, the sixth intercostal space, that is the best desired position, and preferably in the mid axillary line, just slightly anterior. Of course, definitely our preferred would be the posterior axillary line, but nothing will be a problem. So the best is just slightly anterior to the mid axillary line, where you see the red star. And so that's why we're going to place our chest tube for our definitive treatment of tension thorax. And what are the steps in chest tube insertion? One is the positioning, so the patient can lie supine at about 45 degrees. Put the bed at 45 degrees with the arm placed behind the head to help you open out the intercostal spaces. And then clean and prep widely the skin, and then drape head to toe. Remember our triangle of safety, which is the lateral edge of our pectoralis major muscle. We have the upper border of the seventh rib, as you see where you see number 7, which corresponds to the sixth intercostal space. Then we have the medial border of latissimus dorsi muscle, and then the apex of the axilla. That is our triangle of safety, where you can safely insert a chest tube, but we prefer to put it either in the 6th or the 5th intercostal space in this event where you might think you might have a combination of hemo and pneumothorax. So that is the preferred. And once the insertion line you have cleaned and prepped and finished the draping of the patient, remember to get your analgesia very well, because adequate analgesia is very critical for the cooperation of these patients. And then create a wheal under the skin with lignocaine at the incision site, and anesthetize all the subcutaneous tissue, the intercostal muscles, the periosteum of the rib up to the parietal pleura, and keep at least a reserve syringe with lidocaine just in case the patient pain. Make a small incision about half to 1 interspace level below the entry site, so that the tube is angled a bit. Then tunnel through the subcutaneous tissue with a curved artery forceps, and gently and bluntly puncture the parietal pleura in a controlled fashion so that you don't injure the underlying lung. Then you can take through your small finger and palpate the lung parenchyma if you can. Sometimes you may not be able to palpate the lung parenchyma, and then push in your chest tube that is clamped on the curved artery forceps. And our aim as we push in the chest tube, we want to go superiorly. So you go posteriorly towards the back, but superior as well, so that the air, which usually tends to gravitate outwards, can be drained out all. And then secure your tube very clearly with a stitch, preferably nylon number 0, so that it is anchored in place. Remember to put 2 stitches that will anchor, one for anchorage and one that you'll use when you're removing the chest tube. And then once you have secured your tube and you're sure it's not going to fall out, unclamp the tube and then connect it to the underwater seal collection chamber. And then over time, we need to keep monitoring to see if this pneumothorax has been drained. And how can we do this? We can do it clinically, we can do it radiologically and physically. Clinically, you want to listen to the chest and see, confirm that now you have breath sounds, which is a sign that you have expansion of this chest. And two is that you look at the meniscus, the swing in the meniscus in your collection chamber. If the swing in the meniscus is less than 3 centimeters, then you know you've drained out most of the air. And so we can radiologically do a chest x-ray to confirm lung. And then two, we look at open pneumothorax stroke, a sucking chest wound. And clinical features, you have an open injury to the chest wall, and this causes reduction. You can have reduction also in the breath sounds, and you have decreased expansion of the chest wall on the affected side, and resonance to percussion because you have air within the chest wall. And there is, of course, equilibration between intrathoracic and atmospheric pressure, and air that passes through the chest wall defect on each breath affects the ventilation, leading to hypoxia and hypercarbia because it's also a one-way sucking into the chest wall. The air goes into the chest wall but does not. How do we treat a sucking pneumothorax or an open pneumothorax? One is that want to close the defect with an occlusive dressing. So any occlusive dressing, we can have petroleum gauze, plastic wrap can be used as a temporary measure. And we dress it on 3 sides as you see on the picture on the right hand corner, so that air escapes from the pleural space to the outside, but air does not go back in. It acts as a valve. This 3-way strapping helps us to act as a valve so that only air can get out of the chest wall but does not go into the chest wall. And definitively, you have to place a chest tube, and preferably in a different site away from the site of injury as soon as possible. Sometimes these patients may require intubation and ventilatory support. And when you look at the wound, the size of the wound, the level of contamination, if it's necessary, obtain a surgical consult for wound. Then next we have frail chest and pulmonary contusion. Clinical features, one, you have a segment of the chest wall that does not have bony continuity with the rib cage. And so you have fractures of 2 or more adjacent ribs in 2 or more places in different planes. And so when you have these fractures, it creates an unstable segment of the chest wall. And so there is paradoxical movement. So at that place that is unstable, when you breathe in, as the chest wall is expanding, this other portion that has the fractured ribs goes in. As you breathe out, it comes out. So it creates that paradoxical motion, and so leads to abnormal respiratory motion. And so you can also have crepitus of ribs if you palpate. And the biggest issue in the frail chest that affects the work of breathing is the underlying pulmonary contusion because of the fractures that have injured the lungs, but not the mechanical wall instability of the chest wall. And so the restricted chest wall movement is associated with a lot of pain, and also the underlying lung injury causes major hypoxia. Treatment for frail chest and pulmonary contusions, we have the initial treatment and then the definitive treatment. Ensure adequate ventilation for these patients, preferably with humidified oxygen, fluid resuscitation just like for any patient, but don't do fluid overload, and adequate pain control because fractured ribs can be very painful. And then definitive treatment, we still ensure that we have adequate oxygenation, where we aim for at least an oxygen saturation of above 92%. Then judicious fluid administrations, or always taking note not to get a fluid overload. And then adequate pain control, because the more we control pain, the better the ventilation of this patient. And we can give them oral analgesics to control pain. We can do intercostal nerve blocks, and now that we have anesthesiologists, they can help with these intercostal nerve blocks. We can have intrapleural, extrapleural, and epidural analgesia. These help to control pain, and thus they improve the work of ventilation. For some patients, because of the underlying pulmonary contusion, we might require some short-term intubation and ventilation so that the respiratory effort can. Then we go to a massive hemothorax. What do we mean by massive hemothorax? It means rapid accumulation of greater than 1,500 cc's of blood in the chest cavity. Clinical features of massive hemothorax: one, we have a dullness to percussion because this is all fluid filled. So when we percuss on the affected side, it is very dull. You have no breath sounds on the affected side because the lung has collapsed. Decreased chest movement on the affected side. Hypotension and shock, secondary to the severe blood loss, but also the impaired venous return. And then you will have hypoxia, arrhythmias, and sometimes you can have accompanying thoracic injuries. And this massive hemothorax commonly occurs with penetrating chest trauma, but also some cases of blunt chest trauma, you can have a massive hemothorax, though it's not a very common. How do we manage massive hemothorax? One is our initial treatment. Always remember our ABCs, as we said: airway, breathing, and circulation. And then we want to aim at restoration of the blood volume, because this patient has lost significant blood, 1.5 liters of blood. So we want to restore blood volume with crystalloids, and preferably, if we can, we restore it with blood products. And then we decompress the chest cavity with a chest tube as immediately as we can. Sometimes, most of the time, the chest tube is sufficient, but as we had said that in about 15 to 30% of patients, we may require operative intervention. And so these are some of the indications for early thoracotomy by a surgeon. One is that if you put a chest tube and you drain more than 1,500 mils of blood immediately, then you know you might require an early thoracotomy by a thoracic surgeon. Two is if you have more than 200 mils per hour for the next 2 to 4 hours, that shows you significant bleeding. So this is a patient who requires an early thoracotomy. And then three, we look at persistent need for blood transfusions due to ongoing bleeding. So you keep giving the patient blood, but it's all drained out. Give the patient blood, but it's all drained out. That's another indication for an early. Then we go to cardiac tamponade. This cardiac tamponade literally means accumulation of blood within the pericardial space, and most commonly occurs from penetrating chest injuries, but also can occur from blunt chest trauma, or any blunt trauma to the chest can give you cardiac tamponade. In some patients, it can develop rapidly, but in some others, it can develop slowly. Clinical features of cardiac tamponade, or there is a key triad which we call the Beck's triad. You have hypotension, jugulovenous distension, and muffled heart sounds. Hypotension because you have decreased venous return, and so there is compromise in the cardiac output, and so eventually you end up with hypotension. Jugular venous distension, because of the decreased venous return, you have engorgement of the neck veins, which are the jugulars. So when you look at this patient, their neck veins are all engorged and distended, and they are very visible. And because you have a lot of blood within the pericardial space, the heart sounds are muffled. You can hardly hear the normal heart sounds of rap, but you just hear muffled heart sounds. And you also can also have the positive Kussmaul sign, indicating a rise in the venous pressure with inspiration. And most of the other signs are similar to the signs of tension pneumothorax. How do we manage cardiac tamponade? One, we need an echocardiogram if we can, but in most of our settings, we do a fast scan, and through the subxiphoid window, we're able to confirm cardiac tamponade. And once we have confirmed cardiac tamponade, always remember to resuscitate the patient, the ABCs, fluids, oxygen supplementation, while waiting for the definitive treatment. And we can do a pericardiocentesis, which can be diagnostic, but also therapeutic for immediate relief, so that we're able to drain out the blood, but it's not the definitive treatment. Our definitive treatment is operative evacuation by a surgeon via a pericardial window, or what we call pericardiotomy. That is the definitive treatment for cardiac. Some lethal injuries to the chest, often not obvious on physical exam, but we should have a high index of suspicion. These are lethal injuries, meaning they kill. One, you have a simple pneumothorax. Some of these things can be missed. A hemothorax, where you have less than 1,500 cc's of blood, pulmonary contusion, tracheobronchial tree injuries, blunt cardiac injury, traumatic aortic disruption, traumatic diaphragmatic injuries, and blunt esophageal rupture. So let's look at a simple pneumothorax. This results in air entering the potential space between the visceral and parietal pleura, which is our pleural space, and can result from penetrating and also from blunt trauma. You have lacerations of the lung with air leakage being the most common cause of simple pneumothorax, and these usually result from blunt chest trauma. Clinical signs: you have decreased breath sound on the affected side. You have hyperresonance on percussion because you have air on that side. And treatment for simple pneumothorax is chest tube insertion. And I hope by now we can recall the triangle of safety and the preferred areas of insertion of the 5th and 6th intercostal space, mid axillary line. Hemothorax, simple hemothorax. So one is when we talk about this, remember we talked about massive as more than 1,500 cc's. For the simple, it is less than 1,500 cc's of blood. Causes being lung lacerations. You have lacerations, the intercostal vessels or internal mammary artery, and this can also result either from blunt or penetrating trauma. Also, thoracic spine fractures may be associated with hemothorax. Management: bleeding is usually self-limiting and does not require operative intervention. However, we require a large caliber chest tube to be able to evacuate out the blood. And then we have to do monitoring, continuous monitoring for the blood loss, and also see our improvement in respiratory status. Sometimes we may require to support these patients with some oxygen. And always remember that if you put a chest tube and you have more than 1,500 mils of blood drained immediately, or in the next 2 to 4 hours you have more than 200 cc's of blood drained, and also the need for continuous blood transfusion to support this patient, these patients require an RA thoracotomy. So always remember that at the back of your hands. Pulmonary contusion is one of the most common chest injuries, and you can have respiratory failure developing over time. Therefore, it's important to monitor, evaluate, and re-evaluate the patient over time. And the pulmonary contusions can occur with or without rib fractures. So a patient might have even a clear chest x-ray, or they can have an opacity on the radiograph that can give you a sign. But significantly, these patients have hypoxia and also comorbidities that increase the likelihood of the need for treatment for pulmonary contusion. One, we have to have pulse oximetry for continuous monitoring, and supplement these patients with oxygen. We need to do arterial blood gases, ABGs, an electrocardiogram, an EKG, and assess and reassess for the need for intubation, especially if these patients continue to have low oxygenation. Tracheobronchial tree injuries are rare, but they are potentially fatal, and majority occur within 2.5 centimeters of the carina. Suspect tracheobronchial tree injuries if you have hemoptysis, if you have subcutaneous emphysema of the neck or the face, if you have a pneumothorax with incomplete lung expansion after chest tube placement, and if you have continuous air leak with an endotracheal tube. Suspect tracheobronchial tree injuries. How do you diagnose these? Bronchoscopy is the gold standard, and you will be able to observe for any tears or obvious leaks. Treatment: consult a surgeon, thoracic surgeon, because this usually might be a need for operative intervention. And monitor these patients' respiratory status, and always remember there might be a need for temporary intubation to improve the work of breathing. Blunt cardiac injury can result in myocardial contusion. You can have a cardiac chamber rupturing. You can have dissection of the coronary artery or thrombosis, or you can have disruption of the valves. And typically, patients present with cardiac tamponade. I think you can recall most of the signs, clinical observations: hypotension, dysrhythmias, wall motion abnormalities on ECG. You can have other changes, AST changes, atrial fibrillations, bundle branch block as part of the EKG changes. Under treatment, we need to do cardiac monitoring. We have to keep doing follow-up ECGs, and the risk of dysrhythmias usually decreases after 24 hours. But if you have a rupture of the cardiac chamber, some of these patients may require operative intervention. So always remember, you may need to call a thoracic or cardiac surgeon to help. Traumatic aortic disruption. This is one of the commonest causes of sudden death after motor vehicle collision or a fall from a height. And survivors, if you manage to survive, these survivors tend to have an incomplete laceration near ligamentum arteriosum of the aorta with formation of a hematoma that gets contained, and thus they survive. And the diagnosis, specific signs and symptoms are frequently absent, but you need a high index of suspicion. A chest x-ray, CT scan, transesophageal echocardiogram can help you. Under treatment, we need very good blood pressure and heart rate control. Try to maintain the systolic blood pressure. So we call it, we want to keep this patient hypotensive, a systolic blood pressure less than 100, so that we don't have displacement of a hematoma that has been formed. We aim to control the heart rate and maintain it at less than 80. But this you can only do by placement of an arterial line for monitoring, at least with the help of an anesthesiologist, maintain ongoing resuscitation, and if you think there might be need for surgery, please have a surgical consult just in case there is need for operative intervention. Chest X-ray findings for traumatic aortic disruption. You have a very widened mediastinum. As you can see in number 1, it is a very widened mediastinum. You have loss of the aortic knob. So our aortic knob is lost. And then you have tracheal deviation uh, to the right. You have deviation of the left main stem bronchus, elevation of the right main stem bronchus, left hemithorax, because that can occur because of the rib fractures. You have a fractured first or second rib, and also you might have deviation of the next is diaphragmatic ruptures, commonly diagnosed on the left side. The right side, it's very rare to have a diaphragmatic rupture there because the liver obscures and protects the defect on the right side. So the liver is like a cushion for you on the right, so rarely will a patient come in with a rupture of the diaphragm on the right. Most commonly, blunt trauma that leads to large radial tears, and these usually head to herniation of bowel into the chest wall. Penetrating chest traumas, usually they are small perforations and they can take time to develop into diaphragmatic hernias. But if you have blunt trauma, especially to the abdomen with increased intra-abdominal pressure, that can give you rupturing of the diaphragm, especially on the left side with instant herniation of abdominal organs. And these injuries can be missed during the initial evaluation, but over time undiagnosed injuries usually result in pulmonary compromise and plus entrapment or strangulation of peritoneal contents, which is bowel that has herniated into the chest. How do you diagnose diaphragmatic rupture? So chest X-ray. Obviously, on the chest X-ray, you'll see an elevated diaphragm, most times on the left, and these injuries frequently missed on the initial chest X-ray. They can be misinterpreted as a hemothorax when you have bowel herniating. And if the injury on the left side is suspected, insert an NG tube or an orogastric tube, and if seen in the thoracic cavity, then you don't need to do any further imaging. So insert a chest tube and do a chest X-ray. If you see, insert an nasogastric tube and do a chest X-ray. If you see the NG tube coiling up in the chest, then you know you have diaphragmatic rupture. Sometimes you may need to do upper gastrointestinal series with oral contrast to see where the contrast is pulling. If the contrast pulls in the stomach up in the chest cavity, then you know you have diaphragmatic rupture with herniation. Treatment, you definitely need surgical repair, so we must have a surgical consult for primary repair, and also consider early intubation because of the compromise in the work of breathing. Esophageal trauma, most of the time results from penetrating trauma. Blunt injury to the esophagus can be caused by forceful expansion of gastric forceful expulsion of gastric contents into the esophagus. If you have, for example, blow on the abdomen, it can give you that forceful expulsion and so can give you tears of the esophagus. and this usually lead, you have linear tear in the lower esophagus causing leakage into the mediastinum. The risk of mediastinitis is very high, and also possible will follow. Management of esophageal trauma. Clinical picture, you consider it one if you have a left pneumo or hemothorax without any rib fracture, consider esophageal trauma. If there is a history of a severe blow to the lower sternum or epigastrium with resultant pain or shock out of proportion compared to the injury, particulate matter in the chest tube, after the blood clears, then you see particulate matter, especially from the food that has been eaten, and the presence of mediastinal air usually shows you have rupture of the esophagus. And diagnosis can be seen at endoscopy, and also upper GI contrast studies can show you leakage of contrast into the mediastinum, indicating trauma to the esophagus with ruptures and a through and through tear. Treatment, definitely we need surgery for drainage of the pleural space and also the mediastinum with direct repair of the esophageal injury. And this should be done early because mediastinitis and empyema formation is very dangerous. Mediastinitis, once you get it, the risk of survival is very then rib fractures, sternal fractures, scapular fractures. So ribs are most commonly injured structures in the thorax, secondary to trauma, and usually pain results from splinting of the thorax, and this impairs ventilation, oxygenation, and also the effective coughing decreases, and thus leads to atelectasis and pneumonia. Fractures of the scapula of the sternum, first and second ribs, most of these, it's high magnitude of injury that might have serious associated injuries with very high mortalities. If you have fracture of the first and second ribs, most of these end up with aortic disruption and you have instant death at the time of injury. The middle ribs are usually 4 to 9, sustain majority of blunt trauma. Majority, if you go through most of the cases in accident and emergency who have rib fractures, the most fractured ribs are usually 4 to 9 with blunt chest trauma. And then the lower ribs 10 to 12. If you have fractures of these ribs because of the nature that the spleen and the liver tend to lie just under these ribs, once you have them, always have a high index of suspicion for hepatosplenic. And then thoracic fractures, our diagnosis, clinically you can palpate, or you have a visible deformity, you can do a chest x-ray and see the fractures, or a CT scan see these fractures. Treatment for thoracic fractures, pain control to improve ventilation with oral analgesics, opioids or NSAIDs, intercostal nerve blocks, intrapleural, extrapleural, and epidural analgesia. These give you very good pain control. And if a patient is elderly, admit them. If someone has more than 3 rib fractures, or if you suspect any other injury, admit these patients for close monitoring. And also remember that these patients are likely to have an underlying pulmonary contusion, which might warrant need for temporary intubation. Supplement these patients with oxygen and do adequate pulmonary toilet to avoid pneumonia. Chest trauma management principles. Remember effective resuscitation, rapid identification and treatment of life-threatening injuries. As you identify any injury, make sure you treat it. Don't forget our ABCs, and the most critical procedure in management of chest trauma is chest tube insertion to drain blood or air from the pleural space, and this you must master it very well. Some resource limited settings. If you have suspected pleural collection, for example, a patient suffered blunt chest trauma, chest x-ray does not clearly show rib fractures, hemo or pneumothorax, but you suspect either of these, or you may have no access to a chest CT scan to confirm if a patient has a rib fracture, especially as we said, if a chest x-ray does not show you this clearly. Aspirate the pleural cavity to ascertain if there is blood or air, and make sure you aspirate the most dependent area for blood or fluid collection. If you want to aspirate for air, aspirate the second intercostal space. If blood or air is suspected, then insert a chest tube and connect it to an underwater seal drainage bottle. If you don't have a special bottle like these ones which are sold, use any large bottle and make sure that the initial tubing from the patient is under the surface of the water, and have an opening, create an opening in the other part of the bottle so that air is able to vent out. You don't need a sophisticated bottle if you don't have access to them. Just use a simple bottle that you might have. Even a normal saline bottle can. If you have severe chest injury and you don't have access to ICU, for example, a frail chest with no ICU services, and ensure that this patient receives high flow oxygen with a face mask, and also give them adequate analgesia. And operative stabilization of the chest wall is rarely indicated and does not offer significant advantage over conservative therapy. Thoracotomy without ICU facilities. A thoracotomy can be performed in an emergency setting, any emergency setting, and once the bleeding is stopped, the patient's hemodynamics may improve and stabilize. And make sure this patient receives supplemental oxygen and adequate. And then we finally look at the case study. So we have this 25-year-old male who was in a bicycle accident in which he hit his chest on a pavement. He's complaining of right-sided rib pain and some shortness of breath. His vital signs: BP of 90/60, a heart rate, that's a tachycardia of 110, and respiratory rate of 38. His GCS is 15. His airway is patent, and he has absent breath sounds on his right chest. So what are the initial management steps for the care of this patient? Remember, ABCs: airway, breathing, and circulation. Once we reach our B, we have seen that this patient has absent breath sounds on the right side of the chest. He hit his chest on the pavement, so it's likely that this patient might be having a rib fracture with an underlying hemothorax, and so we need to place a chest tube immediately for this patient. If we have access to a chest x-ray, first do a chest x-ray for them, but if not, make sure you put a chest tube in the initial management of this. Those are some of the results, and